Chapter 7, Assessment and Documentation for Optimal Care. So we're going to go right into this. All of your chapters are read and prepped. I just need to record everything now. So we're going to start here. The assessment of the older adult is more complex, it's more detailed, and is longer to perform. Geriatric patients vary greatly in health function, from active and independent to medically frail and dependent. You guys will be able to see that in your clinical experiences. Complexity in charting. Remember, if you didn't chart it, you didn't do it. You're going to keep hearing that all through nursing school, and you will learn that all the time as a nurse, that you can say all day long, but I did it. I was just too busy and I couldn't chart it. And that's going to mean you didn't do it. The quality and speed of the nurse's assessment are a reflection of the experience. So doing these assessments of the older patients, which we're going to learn in a minute, actually we have to do a little bit more focused assessments on the certain issues that are going on versus complete full head to toes, unless that's what kind of line of business we're in. So the collection of data from our patients, we're going to do biological, psychosocial, and functional information, cultural and spiritual assessments, cognitive abilities, psychological well-being. We're going to be assessing the caregiver for their stress or burden that they're going through, if they have one, patterns of health and their health care of the patient, and review of preferences for advanced care planning. Frequent problems to address in an assessment, most of which are under-addressed. Here's your list here. Sexual function, depression, incontinence, alcoholism, hearing loss, oral health, and environmental safety. And all of these, for the most part, if you think of our older adults, there's some kind of stigma or embarrassment that go along with many of these. So again, they're under-addressed, under-assessed, and we need to make sure that they're not. Our special assessment abilities as a nurse, we need to listen patiently. You know, our older adult sometimes has harder time recalling information or talk slower. We need to be patient as they go through the different things we're asking them, having them find the information. Allow for pauses, ask questions that are not often asked. We just discussed that. So this is where we're digging into how many alcoholic beverages do you have per day? We're talking to them about their feelings of sadness. We're talking to them about their elimination patterns and asking, are you ever incontinent of urine or feces? You know, this does not need to be embarrassing. They need someone to be able to talk to. And so in order for us to implement the right things for them. Know that not all positive findings need interventions. That is also true. So again, if I find out that the patient is incontinent of urine, but have been managing it fine with poise pads, haven't been having infections, it's not a ton, and they're not dealing with any kind of skin breakdown over it, I may not have to do anything. You need to know your normal changes, and a patient pace the assessment according to the patient's stamina. So again, they kind of lead it based on how quickly or how slowly they need to do it. Collecting the data. So we first establish a rapport. This is in the orientation phase with our patient. This data collection includes self-report, either written or verbal data from the patient, a report by proxy. This is from caregiver or other healthcare worker. And then observation, your book says this is best in accuracy, but it's limited for the time frame, so it's not good for the big picture, because our own observations can tell us exactly what we're seeing. We can see exactly what the heart rate and blood pressure, their affect, everything that's going on in that time we're with them. But if it's only 1 hour, it doesn't give us a good picture of overall. Guidelines for the assessment: conduct the assessment at the time that is best for the client. So if an early morning interview would be better than late night because a patient has sundowners, then obviously we want to schedule that in the beginning. Avoid biasing your responses. Explore more information, but only if needed. Approach sensitive information in a matter-of-fact manner. So we want to make sure that we are professional, is basically what that's saying. So if I'm going to talk to them about their sexual life, I need to be matter-of-fact, not opinionated at all, not any tone that indicates I'm embarrassed to ask. I need to ask like a professional. and I want to record the client's words for accuracy. And remember, when you're doing charting, your electronic charting, you want to make sure that you put quotation marks around what a patient says directly. Health history is collected in a face-to-face approach with the client or a review of the client's written history. Includes medical history, review of systems, medication history, nutritional history, and factors that influence a person's quality of life, including living arrangements. So does a person live alone, or do they live with someone else, or what is their living situation? Their financial resources, like we want to look at what their payment for medications is, and other healthcare access if they have a lot of out-of-pocket expense. And what kind of support systems do they have from family, friends, caregivers, etc. This is part of the health history that we want to take from the patient. The physical assessment, I kind of mentioned this earlier, is very time-consuming. It begins at the moment the nurse sees the person. So as soon as we walk through the door, we're looking how they are dressed, how they appear. We're looking at the skin that we can see that's not covered by clothes. If we're able to see them walk to a certain place, we're recording and noting the gait. We want to perform a problem assessment first, which means what is the chief complaint that they're coming with. I want to look at that because of the length of time it does take to conduct an assessment. When the focus is a well check assessment, the emphasis is placed on health problems in later life. So I'm going to be looking at fall potential and gait and hearing and vision and different things that are problems that are typically seen later in life if I'm just doing a well check visit. Assessment for the frail and medically complex. So there is a model that's called FANCAPES. FANCAPES. So that stands for fluids. And so I'm looking to see what is their current hydration, aeration, their respiratory function, nutrition. This is the food consumption, their oral integrity, their risk for aspiration. Oral integrity is such an overlooked thing, and we have to be really, really diligent with our older population with this. They do not report their mouth sores. They do not report their loose-fitting dentures. They do not report if they're not wearing them. We need to assess their nutritional status. Communication, the patient's ability to communicate their needs. Activity, do they need any assistance? Are they able to perform their ADLs, like getting dressed and taking a bath and making food? Pain, not just physical pain, assess psychological or spiritual pain. Elimination, do they have lack of control? Factors that interfere being able to get to the restroom, or if they have things that they're out doing, do they not drink enough fluid because they're afraid they're going to pee? Socialization, their own self-worth, do they receive love and friendship? Mental status assessment, we assess whether an increase in chronological age has resulted in an increased rate of dementing illness. Assessing cognition and mood. So this is something that we actually have already talked about some. We want to see where their cognitive status is, the baseline, and get a background history on that. So tools for cognition and assessment, we're going to go through these. I'm just going to go right to the next slide. So the mini mental state examination, this tests orientation, short-term memory, attention, calculation, ability, language, and construction. It cannot be given to patients who cannot read or write or speak English, and it is a 30-item instrument. This is lengthy. You can look these up on the internet and look at different ones, but you can see here on the one that I've attached, there's orientation to time, orientation to place and year, name of the place or building floor. So all kinds of stuff in there. The recall of the 3 words. You tell them 3 words and ask them to recall and give them to us. The repetition, the closing their eyes, the drawing, all kinds of stuff. But this is not the one that's most recommended anymore, so we're going to keep moving. There's also the clock drawing test. This identifies cognitive impairment and measures the severity. Not appropriate with patients who have limitations in their dominant hands. So they'll also do this with staging dementia and Alzheimer's patients. They'll ask them to draw a clock and ask them for a certain time. And as you can see in the first one over here, pretty close to okay. You know, 6, 7, and 8 are sort of spaced out a little bit further, but pretty okay. And then you have over here that all the numbers are there and they all go around, but this whole side over here is not. And then you can see with more advanced, you know, there's the round circle, there's the numbers. There looks to be something that might have been trying to point at something, but gets worse with time. And if you do look this stuff on the internet, there's a lot of good examples and shows you with the staging of either dementia or cognitive impairment. And then there's the mini cog. This is quicker than the first one that we talked about and is now the evidence-based tool that is recommended. Basically what it does is it combines the short-term recall with the clock drawing test. So we ask the patient to repeat the 3 words. Then we have them do the clock drawing test, and then we ask them to repeat the 3 words again. And then from there they're going to get a score. Functional assessment, so to determine the functional status of the client, including identifying areas where help is needed, determining whether a change in abilities from one period to another has occurred, assisting in the determination of a need, and determining the safety of a client's living situation. If the client is healthy and active, record a simple statement such as the client is active and independent and denies functional difficulties. Functional abilities, activities of daily living, those are all listed there, and then instrumental activities of daily living, house cleaning, shopping, and managing money. Functional assessment tools, tools to assess activities of daily living. You have your CATS index, table 7.2 on page 98, Barthel index, page 98, and functional index measure on page 98. Make sure you go over those. Tools to assess instrumental activities of daily living is box 7.4 on page 99. Also see pages 96 and 97, box 7.3 for functional performance test, mobility. That will all make sense when you dig into that, so make sure that you go all over the stuff that I've put on there. You will see it. There's other tools. I'm not including any of that stuff, and we're not really going over that. The Fulmer spices, though, is sleep disturbance, problems with eating and feeding, incontinence, confusion, evidence of falls and skin breakdown that a lot of institutions will use. Implications for geri nursing and healthy aging. The goal is to promote healthy aging. Tools serve as a way to collect data and organize data. Each tool has strengths and weaknesses. Documentation, again, this is going to support and communicates the client's condition, helps the nurse identify, monitor, and evaluate treatment or interventions, communicates quality of care, and determines reimbursement. That determines reimbursement is really important on that for us because a lot of things we do not get reimbursed for if we have not documented effectively. And again, in the red back there, it said that if you did not document, you did not do it. Our documentation types, mostly just EMRs now. Yes, we had SOAP notes and problem-oriented narrative notes, but we really don't do a ton of that stuff anymore, mostly just the EMRs. And then home care documentation, I just threw this in here, FYI. Medicare and Medicaid have strict criteria for documentation, such as outcomes and assessment information set. That's that OASIS that you'll see sometimes. If you know a home care nurse, talk to them about that because they know a ton about it. Nurses supplement data collected in OASIS to include pertinent information personalizing the care provided. Implications for geri nursing and healthy aging. Several forms of documentation are available. Know your own institution's documentation preference. That is very, very important. We learn the different documentation systems that they use based on where we work, and always know what correct documentation is. And if you don't know, you need to ask. Communicate important information regarding safe client care, and documentation should be high in quality and error-free.